Good afternoon, everyone. I am Aaron Pollitt, the Provincial Head for Pathology and Laboratory Medicine at Cancer Care Ontario, the Canadian Association of Pathologists, the Canadian Partnership Against Cancer, and Cancer Care Ontario. I would like to thank everyone to today's CAE Cancer Protocol education session on head and neck cancers. Before we introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. The session is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. The live presentation and the recorded presentation are eligible for CME credits. Info for obtaining credits can be found in the session notice. Please note, certificates for each of the education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Has been automatically muted for today's presentation. We have a number of participants and will not be able to troubleshoot WebEx issues as part of this call. If you are experiencing technical difficulties, please call the WebEx support line. We encourage you to submit questions at any time during the presentation using the chat feature within WebEx. Instructions can be found in the session notice. During the question and answer portion of the presentation, a session moderator will put the submitted questions on your behalf for as long as time permits and in the order in which they appear. In the chat window, please include the following information: your institution, your name, and your question. It is my pleasure to introduce Dr. Martin Bullock. Dr. Bullock practices anatomic pathology at the Queen Elizabeth II Health Science Centre in Halifax, Nova Scotia, specializing in head and neck pathology. He is a professor of pathology and surgery at Dalhousie University. Martin graduated from medical school at Memorial University of Newfoundland, trained in anatomic pathology at the University of Toronto and University of Maryland. Martin has been involved for many years in synoptic reporting initiatives in head and neck and thyroid pathology with the Canadian Partnership Against Cancer, the Canadian Association of Pathologists, the College of American Pathologists, and the ICCR. In his practice in Halifax, he is collaborating with head and neck surgeons to develop ways to intraoperatively assess adequacy of excision for patients having laser surgery for Oropharyngeal squamous cell carcinoma. There's many questions related to specimen handling, reporting, and HPV testing. Some of these will be addressed today. Without further ado, I introduce Dr. Bullock to give today's talk on head and neck cancer.
Good afternoon, everybody. I hope you can hear me. So as Aaron said, I'm going to be talking today about the new updated CAP head and neck cancer protocols and about the new, how those interrelate with the new TNM staging system that came into effect on January 1st. Just first off, I have nothing to declare. I have no relationships with any commercial interests. We're going to talk about the checklist for head and neck cancer in the College of American Pathologists cancer protocol. We're look over some of the major changes to the ACC TNM staging system that came about the 8th edition. We're the checklists with a particular emphasis on the pharynx and oropharyngeal HPV-related cancer, and we're going to talk about some of the significant changes to those checklists. And I'm going to try and emphasize some of the practical issues that I face with interpretation and some of the things that I find quite difficult. And maybe if people have difficulties or solutions to these problems, they can call in or ask questions or make suggestions. So these protocols were updated as of June 2017, and as of January 1st, 2018, we're all using the late 8th edition of the AJCC staging manual, and the tumor classifications that are included use the 2017 version of the WHO Blue Book. So we'll talk about the larynx, pleural cavity, salivary glands, nasal cavity and paranasal sinuses, and most importantly, the pharynx. In addition, there were quite significant changes to the AJCC staging. This is really part of the AJCC's vision of what maintains its basis of staging in anatomical parameters and extent of disease. They're to incorporate molecular biomarkers for more accurate disease stratification. So all disease sites, if relevant, will be incorporating non-anatomical prognostic factors. And AJCC to progress from a population-based to a more personalized approach, and addressing personalized survival outcomes through risk assessment models and clinical trial stratification. So in the pharynx, there's been some significant changes. In the 7th edition, there was just one chapter that covered the nasopharynx, oropharynx, and hypopharynx. There are 3 different primary tumor categories for those 3 sites. There are 2 different end categories for the nasopharynx and for the combined oropharynx and hypopharynx. And the pharynx and hypopharynx categories were very similar to the end categories for other head and neck sites, or actually. But in the 8th edition, they've divided the pharynx into 3 chapters. Nasopharynx, which, as you know, primarily nasopharyngeal carcinoma, which is an EBV-related disease in the vast majority of cases. And there's also a new chapter addressing HPV-mediated, which means P16 positive oropharyngeal cancer, and then 16 negative oropharyngeal cancer and hypopharynx cancer has its own chapter. And so there are now distinct T and N categories for oropharyngeal squamous cell carcinoma based on the AV status. There are other significant changes to the head and neck cancer staging. For sites, the T0 category has been eliminated. So 0 meaning no evidence of a primary tumor after it's been surveyed. With the exception of HPV-positive oropharyngeal squamous cell carcinoma and nasopharyngeal carcinoma. For the oral cavity, the main change has been that the T categories added the element of depth of invasion. And depth of invasion has been divided into 3 steps of less than 5 millimeters, 5 to 10 millimeters, and more than 10 millimeters. And the T4 category, which used to include involvement of extrinsic muscles in the tongue, that has been dropped, which is actually helpful because it's extremely difficult for pathologists, I think, and radiologists to assess involvement of the extrinsic musculature of the tongue. And in fact, the depth of invasion is a more relevant prognostic indicator. Now also, for most disease sites, again, except the HPV-related oropharyngeal squamous cell carcinoma, externodal extension has been added to the N category. And in summary then, for 5 millimeter depth increase of an oral cancer, that increases the T category by about 1 level. Same with the extranodal extension. So the presence of extranodal extension increases the N category by 1 level by large. There are new chairs and staging systems for other sites. So there's now a specific chapter that's dated to involvement of cervical lymph nodes and unknown primary tumors of the head and neck. That applies only to squamous cell carcinomas, the P16 negative and an unknown primary. The idea is that if you have a P16 positive tumor in level 2 or 3 of the neck, that is an HPV-mediated oropharyngeal squamous cell carcinoma. The chapter for cutaneous squamous cell carcinoma of the head and neck, and the staging for soft tissue sarcomas has been written so that there is now a site-specific staging of soft tissue sarcomas. This really reflects that there are lower cutoffs for progression from one stage to the next than for non-head and neck sites. And this really reflects the fact that these tumors in the confines of the head and neck to behave in a more aggressive fashion when they are smaller tumors. So getting to the CAP protocol then, with the pharynx case summary. So the pharynx case summary does cover the entire pharynx, nasopharynx, oropharynx, and hypopharynx. It covers resections for carcinomas and melanoma. So in carcinomas, that includes squamous cell carcinoma, neuroendocrine carcinomas, and minor salivary gland carcinomas. It doesn't cover sarcomas or lymphomas. The main changes from the prior versions are that we're using the new staging system. We're new WHO Blue Book Histologic Type categorization. And importantly, as I'll talk about in a few minutes, that need to assess extranodal extension and optional category to subcategorize extranodal extension to minor versus major, which I'll explain later. Ancillary studies section has been dropped from each of these protocols. Now there is a series of CAP biomarker templates, including for head and neck, which addresses all the potential ancillary studies that you can use for head and neck cancers. So AV, mediated oropharyngeal squamous cell carcinoma, is an epidemiologically, pathologically, and clinically distinct form of head and neck cancer. And it's been described as an epidemic, and I don't think that's an unreasonable thing to say. I would say that every week, and more than once a week, I diagnose a case of HPV-mediated oropharyngeal squamous cell carcinoma. They're extremely common. These tumors are mediated by high-risk HPV serotypes, 9% of them by HPV-16. They tend to occur in patients who are young, usually male. They're typically patients who are between 50 years old and in their early 60s, say 65. Patients who are generally healthy and they have little or no tobacco exposure. Tumors occur in the tonsil and the base of the tongue. Other components to the oropharynx, including the soft palate. A soft palate tumor, they're not usually of HPV origin, thought to arise within the crypts of the tonsils or in the crypts of the lymphoepithelial tissue in the base of the tongue. Their morphology is almost invariably non-keratinizing without the presence of squamous maturation. So it's not uncommon that you will see some squamous differentiation and even keratinization in these tumors, but don't have the morphology of a typical keratinizing squamous cell carcinoma in cases. 50% of patients, a large neck mass or a neck mass will be the primary presenting feature. And the vast majority of these patients, 90% or so, actually do have neck metastases at the time of diagnosis. And in the oropharynx, P16 is a reliable surrogate marker for HPV status. So we consider specific tests for transcriptionally active active HPV to be the gold standard, the best probably being hybridization for mRNA. P16 is a highly sensitive marker, which has very good correlation with HPV status by mRNA situ hybridization, oropharynx. And so it is a very reliable surrogate marker. And for this reason, the AJCC and CAP in their recent HPV headlines, head and neck carcinomas, that direct detection of HPV is not required in oropharyngeal squamous cell carcinoma. So all oropharyngeal squamous cell carcinomas should be tested for P16, regardless of their morphology. And are P16 positive, they don't need to be graded, and I'll talk about that as well a little bit later. Back to that CAP protocol, as with the other CAP protocols that has the basic information there, the procedure that was performed, the tumor site, whether it's nasopharynx, oropharynx, or hypopharynx, laterality, focality, and size of the tumor. These protocols are meant to be used with resection specimens, of course, and just depending on your hospital, you may not actually get oropharyngeal resection specimens. We certainly get lots of them here, but in many institutions, oropharyngeal cancer is with chemotherapy and radiation, and so you don't actually see the resection specimen. It can often be difficult to actually know how big these tumors are. The TLM protocols, the transoral laser microsurgery protocols that we use here, actually divide the tumor so the surgeon can see the operative bed and see how deep the tumor is. And so it's difficult to reconstruct these tumors, and it's very important to have correlation with the surgeon and a discussion with the surgeon so that you can know exactly how big these tumors are. The next component of the protocol is the histologic type, and human papillomavirus-mediated SCC is given its own category, and then there is HPV unrelated or HPV negative squamous cell carcinoma of the pharynx. Is the oropharyngeal squamous cell carcinoma HPV status unknown if it's not tested, and pharyngeal squamous cell carcinoma. And so with those categories that I've just mentioned, you can actually choose the variants that occur. So as I said, most of the HPV positive squamous cells are squamous non-keratinizing, but we variants, and that includes, well, most commonly it's papillary squamous cell carcinoma. Oftentimes these tumors will be papillary on the surface with a component that is more just conventional non-keratinizing squamous cell carcinoma. Sometimes they can be purely papillary, but that's rather uncommon. Can be basaloid. So not really accurate to describe these non-keratinizing carcinomas as basaloid, because the basaloid variant of squamous cell carcinoma is really a very particular phenotype, in which the tumor cells are basaloid, yes, but they have other features such as peripheral palisading. They'll often have production of matrix, they'll have necrosis, and they may have a nested or community-type pattern or a sort of a jigsaw puzzle-like pattern. So a basaloid squamous cell carcinoma is a variant, and it's not synonymous with non-keratinizing squamous cell carcinoma. And the other one that we do see from time to time is adenosquamous carcinoma, and I'll show you an image of that a little bit later. The interesting thing is that really these variants, if this is an HPV-mediated cancer, the variants don't behave any differently than the usual non-keratinizing carcinoma. So even though we do the variant if it's present, they behave any differently. And that's somewhat different than HPV-negative cancers because myeloid squamous cell carcinoma, if it's HPV-negative, does tend to have a more aggressive characteristic, as does adenosquamous carcinoma. So the interesting feature of these HPV-mediated cancers. You do see a spindle cell component in the HPV-mediated cancers. Often the cells look a little bit spindly or elongated, but they aren't really per se spindle cells. Do on occasion see an actual spindle cell or sarcomatoid component to an HPV-mediated cancer. In my experience, it doesn't usually occupy the whole tumor. A fairly typical example of, or two typical examples of HPV-related oropharyngeal squamous cell carcinoma. On the left, you can see the tumor is to a crypt, so there's the crypt, and here are these islands of tumor cells. They tend not to elicit much of a desmoplastic response. So sometimes, I'll get these cases in consultation, and there will be a question as to whether or not they're really invasive. And the answer is that it doesn't really matter, because we usually just call these non-recognizing squamous cell carcinomas HPV-mediated or P16 positive, regardless of whether or not you actually see tumor confined to the crypts or whether you see tumor that's in the underlying stroma. You don't actually need to specify invasive, because they're all assumed to have that capability of metastasizing. So these tumors will form these large islands of cells with or without stromal desmoplasia. Sometimes they will actually mature towards the periphery. Sometimes there'll be even acidic response around these peripheral cells. The right-hand side has a more kind of reticular or trabecular pattern, and you see that they will show maturation in quite a large number of cases, but the maturation is limited, and it doesn't take on the fact that the bulk of tumor does have this non-keratinizing phenotype. So you can call these non-keratinizing carcinomas with squamous maturation. It doesn't change the fundamental diagnosis. Tumors stain with P16, and P16 cutoff that is most commonly used and that is recommended by the College of American Pathologists is greater than 70% staining with nuclear and cytoplasmic of at least moderate to strong intensity. In this case here, you can see these microcysts by very strongly positive tumor cells. You can see there is some staining of the adjacent normal epithelium, and I call this kind of a mosaic staining, where individual cells or individual groups of cells have staining of variable intensity. It can be nuclear and cytoplasmic, and it's very common, especially in the crypts, but it does occur in the surface epithelium as well. You'll see kind of staining, for instance, in lymphoepithelial cysts at the base of the tongue, and that is not positive staining. What you have to see is this very intense staining. And usually, the issue is not usually whether it's more than 70%, because it's usually almost 100% when they're positive. So the issue of the cutoff is not usually a difficult one to resolve. Tumors arise primarily within the crypts of the tonsils or the base of the tongue, and some can be very tiny. This case here, actually, you'll have to take my word for it that there were some basaloid cells down here at the base of this crypt on the left-hand side. This was actually in a contralateral tonsil to the main tumor, and you can see this very small focus of cancer. And is that essentially these tumors can be very tiny, can be confined to the crypts, and they can still metastasize. So even if they're confined to the crypts and they don't sort of conform to our conventional notions of what invasive carcinoma is, that these tumors still can gain access to lymphatics and they can still metastasize, and they should all be called squamous cell carcinoma regardless of whether they seem confined to the crevice or not. This is an example of a tumor that was excised by transoral laser microsurgery. This patient had a large cystic mass, and on the TL protocol, this tiny little 2 millimeter or so cancer was found. And it's not a common situation where you'll have these tiny cancers with a big neck mass. Example of the adenosquamous variant. So you can see on the left that it's fairly typical non-keratinizing squamous cell carcinoma. You can see there's some larger kind of polygonal squamous cells on the left-hand side. And then parts of this tumor you can actually see gland formation. You can see some here at the apex of the cells. And, in these cells, I don't think we can really see it very easily, but in parts of this tumor there were actually cilia on the surface of these columnar cells, which is kind of an unusual event in cancer, that you will actually find cilia, but there are ciliated cases of these adenosquamous carcinomas of the oropharynx. And as I mentioned, there really aren't, based on the variant, it does appear that the tumors which have what's called anaplasia do tend to behave in a more aggressive fashion. So if you see one of these head and neck cancers with very large, bizarre nodal or multinucleation, so tumor giant cells, these more aggressive fashion. And I think it's worth mentioning that in a comment, even though it's not part of the CAP protocol. This slide just really talks about the other types of cancer you get in the pharynx. So carcinomas in the nasopharynx. By and large, these are related to Epstein-Barr virus, including the keratinizing ones. The non-keratinizing carcinoma category does include both differentiated and undifferentiated or lymphoepithelioma tumors. Big squamous cell carcinoma, that's a fairly new category. It was introduced in 2005. They're very rare. Most of them are EBV related, but very rare, maybe occupying only 1% nasopharyngeal carcinomas. Carcinomas of the minor salivary glands, that's per the WHO categorization. One thing I draw your attention to is neuroendocrine carcinomas. So really, we do see HPV positive small cell neuroendocrine carcinoma of the pharynx, and that is a specific tumor because unlike squamous cell carcinoma of the oropharynx, these small cell carcinomas, even when they are HPV positive, do tend to behave in a very aggressive fashion and should be separated out from other HPV-related carcinomas of the oropharynx. So the case summary goes on to talk about histologic grade, and as I mentioned, you should not grade the HPV-related oropharyngeal squamous cell carcinoma. It's not necessary. The CC variants, like a basaloid or a sarcomatoid squamous cell carcinoma, in the hypopharynx, for instance, those do have an intrinsic biological potential and don't need to be graded. And there are grading for salivary gland tumors, so that's necessary. There are grading systems for salivary gland tumors, which are widely available. With respect to the margins, this is very similar to the CAP protocols for the other head and neck sites. Basically, the margins, you will say whether they can be assessed or not, and involved or uninvolved by invasive carcinoma. If they are uninvolved, you should give the distance to the closest margin. I typically wouldn't give it to anything more than 1/10 of a millimeter. I don't think that it's possible to be more specific than that. There's a lot of inter-observer variability, and some would argue that that even tenths of millimeters are perhaps a little bit too precise. There is uninvolved or involved by high-grade dysplasia. So really grade dysplasia, when we're talking about the pharynx and other head and neck mucosal sites, refers to anything more than moderate dysplasia. So moderate or dysplasia or carcinoma in situ, those would be considered high grade, and that would be required to report that in your protocol if the tumor is negative for invasive carcinoma. It's necessary to report high dysplasia or carcinoma in situ at margins for the UV-mediated oropharyngeal carcinomas, because we really don't recognize an in situ really important when examining head and neck cancer resection specimens to have the specimens properly oriented. So here in Halifax, we use this oropharyngeal cancer template for the transoral laser microsurgery cases, and the surgeon brings the tumor. On these are tumor splits, so that the tumor will be split down the middle. This will allow the surgeon to see the depth of the tumor and the deep margin, and allows them to go around it and come up underneath it. So these cases will often come as two separate specimens, often a superior and an inferior pharyngectomy. Sometimes they may come as three separate specimens. You really have to orient them properly with the surgeon and then differentially ink them so that when you go back and gross them, you can decide which margins you're looking at and whether or not those margins have been properly cleared. But we have started doing this intraoperatively, trying to assess the margins intraoperatively, often grossly, because you can see, in this case actually, you can see that the tumor is really visible. And then sometimes we don't actually put sections through, but sometimes we do, just depending on how close the tumor is. And of course, institutions don't do this type of surgery at all. They treat their oropharynx cancers with chemotherapy and radiations, in which case this is not really applicable to them. So, occasion we do see true surface tumor in these oropharyngeal carcinomas. So tumor that isn't in crypts, that actually extends up onto the surface epithelium. Often this is papillary, but sometimes it's flat. And so what do about that? Does that get incorporated into the size of the tumor, for instance? Well, I've asked a question of several people, and the last person I spoke to was Jim Lewis, who's kind of an expert in this this field, and suggested really that the most important thing would be the gross measurement of the tumor, or the microscopic measurement of tumor that was within crypts and soma. And when measuring the tumor, it's probably not necessary to additionally measure this tumor. But if you see that this at a margin, it would be considered a positive margin. What I'm talking about really is that this is the tumor right here, and on occasion you may actually see some tumor extending out onto the surface of this of the specimen. Really to in situ carcinoma, but we don't call it that. Anyhow, obviously you'd report that if it was at a margin, but when I measurement, I would give her a measurement of that main tumor mass. To get to the other components of the pharynx, nasopharynx, those tumor specimens are not normally resected, so we don't deal with those very often. Oropharynx tumors, we do see them from time to time. They often end up with very big resections, not usually treated by microsurgery, although frequently they are, but usually they're not. And often these tumors are in the piriform sinus, so if we look at this laryngopharyngectomy specimen, you can see glottis here, These are the epiglottic folds. This is the hypopharynx. This is called the post-cricoid area. So cricoid cartilage, we're looking at the specimen from the back. The cricoid cartilage would be just beneath right here. And this mucosa here is called the post-cricoid mucosa. This is the piriform sinus on the right. This is the piriform sinus on the left, and you can see this large kind of fungating tumor, which is extending the piriform sinus. And in fact, the mucosa here, this area epiglottic fold, looks abnormal as well. So from an anatomical perspective, the pharynx, the hypopharynx, actually ends at the inferior border of the cricoid cartilage. And just do another specimen and talk a little about the anatomy. So the hypopharynx is a posterior wall. This is a laryngopharyngectomy in which the pharynx has been removed essentially in toto, as well as part of the oropharynx, because the area right here is where the hyoid bone was. So the hyoid bone was right here. Everything above the hyoid bone is oropharynx, so there's a little bit of oropharynx here, and beneath that we have hypopharynx extending all the way down to the inferior border of the cricoid cartilage. So this is the posterior lamina of the cricoid cartilage right here, and the extends down to there. So tumor, in fact, you can see actually involved the posterior wall of the pharynx in this image, and it involved the post-cricoid mucosa, probably extended into both piriform sinuses, and also invaded the larynx. And of course, in cases, it's very difficult to know where these tumors originate. And so you have to go back to the clinical history and to the surgeon to try and decide, is this a primary laryngeal cancer that's actually involving the larynx, the glottis, and the subglottis, or is it a hypopharynx cancer that subsequently invaded the larynx? Carry on with the protocol again, and with many other sites, of course, you're asked to identify the presence or absence of lymphovascular invasion, perineural invasion, and tumor extension. So I do that tumor extension for invasion of other structures, so you can use it to talk about invasion of cartilage, you can use it to talk about invasion of other structures. If they are present, of course, that would come into the stage, T stage, but it's helpful to have that category there. So the T categorization, using P16 as a surrogate for human papillomavirus positive cancers. There is a significant difference between these two. So in AV-mediated squamous cell carcinoma, there is a T0 category for tumors that are not identified. So that might be, for instance, if you have a big neck mass, it's proven to be HPV positive, for instance, by a biopsy or maybe by an FNA, but you can't find the primary site. That's not uncommon. Be a search to find the primary site. They may do PET scan. They'll do examination of the area, try and find it. And patients will end up in our institution as having an unknown primary protocol where they try and actually excise the entire, say, side of the oropharynx, base of tongue and tonsil, try and find that primary. So in the, and you'll notice that in fact there is no CIS category for P16 positive oropharyngeal squamous cell carcinoma. And in the T4 category, the tumors are all considered to be moderately advanced. Local disease if they invade the larynx, the extrinsic tongue musculature, the pterygoid muscles, the hard palate, the mandible, or beyond. Where for P16 negative cases, there's a moderately advanced and a very advanced categories, T4A and T4B. And really that just reflects the fact that even when these tumors are quite advanced locally, they still tend to have a better prognosis. Component of the protocol is the regional lymph nodes. So as many other sites, you record lymph nodes that are involved, the number of lymph nodes that have been examined, the locality of the lymph node, nodes and the size of the largest metastatic deposit. So it doesn't mean the size of the largest lymph node, it means the largest metastatic deposit. And there are certain circumstances that can be difficult to evaluate, such, for instance, if you have a big conglomerate of nodes, and I'll talk about that in a minute. But sometimes you may have tumor that's dispersed throughout a lymph node, and then how do you measure the largest metastatic deposit? Do you measure the individual deposit of tumor? Do you measure, try and add it up and come up with a conglomerate dimension, or do you measure it from one deposit to another, the greatest dimension that you can find? And all those things are kind of open to question. But what I do is measure the distance between the two most widely spaced deposits. So you would see one end of the node and then at another end of the node, and you would measure the distance between those two. To kind of iterate the neck levels, just to realize everybody. So there are practice neck levels plus level 7. So 1A is submental, 1B is submandibular, then 2, 3, and 4 are the cervical chain of nodes. Level 5 is superior and inferior, and it's posterior to the posterior border of the sternocleidomastoid. Level 6 are the central lymph nodes in the anterior aspect of the neck. We don't typically see those with standard neck dissections. Usually level 6 is involved if you have thyroid cancer, can be involved in some laryngeal cancers, for instance, but usually we don't see them in the standard neck dissections that we get for head and neck cancers. Level 7, the superior mediastinal nodes. So these nodes are categorized as head and neck nodes even if they are in the mediastinum, because they can be involved by head and neck cancer, and they're sometimes resected, usually with thyroid cases, but rarely with head and neck mucosal tumors. So level 7 metastases to level 7, these superior mediastinal nodes, are considered local metastases rather than distant metastases. There are other node groups in the head and neck. We see with certain types, primarily of major salivary gland cancer, parotid cancer, and the head and neck skin. So there are occipital nodes, posterior nodes, parotid nodes, facial nodes, pharyngeal nodes. And usually when they come, they're labeled as such. There is a number system for these additional node groups that is based on very complex anatomical parameters, and that is used by radiation oncologists, for instance, when they're giving radiation to people. We tend not to get those groups labeled as such, but a number system does exist. So just a few notes on submitting neck dissections. It's good if you can, and if the surgeon is cooperative, to have these specimens properly oriented. You have to divide them into levels. It's ideal to actually receive them in individual levels. Sometimes that's not practical from a surgical standpoint, so we won't get that, but obviously orientation is very important. Negative lymph nodes need to be submitted in toto. Grossly positive nodes can be partially submitted, so I tend to, if I have like a neck mass or a grossly positive node or a large soft tissue mass, to give one cassette per center of the tumor dimension. I concentrate on areas of potential extranodal extension. If I do see a think is a soft tissue deposit in musculature, then I would ink the soft tissue margin around that at least, just so you can see whether or not there's margin involvement. Something difficult, to know when you have a conglomerate of nodes or a soft tissue mass, how many nodes is that involving? So if it's grossly possible to estimate it, you can. If you have a soft tissue mass without any evidence of a pre-existing lymph node, then usually count that a 1 out of 1 in my node count, rather than just saying, you know, I've got 15 negative lymph nodes in a soft tissue mass, then, you know, these soft tissue masses, in the majority of circumstances, if they're large, are of nodal origin. So I count all these masses as positive nodes, at least one positive node. So this is an example of what I thought was two separate nodes. I guess it's possible that a sort of a twisted or, you know, rotated node for some reason. But you see there's a fibrous band separating these two areas of tumor, and there's lymphoid tissue in them without any obvious extranodal extension, but there is a matted conglomerate of nodes. When you're measuring that, I would just give the measurement of the actual mass, even if it's involving more than one node. If it's a matted mass, then the greatest dimension should be the greatest dimension of that mass. Sometimes we'll see salvage surgeries. So these are surgeries where the patient has had chemotherapy and radiation, or perhaps just radiation, and they still have a residual neck mass. And when you go back, submit the nodes, the enlarged nodes, you may not find any viable tumor. You may just find keratin with a giant cell reaction, so keratin granulomas. Those shouldn't be considered as positive nodes. But it's important to search those nodes pretty carefully to see if you actually have viable tumor, because sometimes there can be very little viable tumor left. Head and neck cancer, isolated tumor cells, which are defined as single tumor cells, or clusters not more than 2 millimeters. You know, in many sites, those are considered N0. Those are actually very rare in head and neck cancer. Squamous cell carcinoma of the head and neck, it's quite common to see isolated tumor cells. Sometimes you see them in small cell carcinoma of the parotid. You see isolated tumor cells. But we stage those as usual, so any tumor cells is a positive node. There's no evidence in head and neck cancer for calling isolated tumor cells as N0 nodes. Next, we come to the issue of extranodal extension, which is called extracapsular spread or extracapsular extension. The AJC has adopted the term extranodal extension. So it refers to tumor that's found within the confines of the lymph node, extends outside the capsule with or without a stromal response. So in head and neck, negative head and neck cancer, the presence or absence of extranodal extension has a profound effect on prognosis. And it's usually a reason for patients to have adjuvant therapy and radiation. In HB positive cancer, the prognosis of extranodal extension is not well established. And in fact, it seems that the number of lymph nodes is more important than the presence or absence of extranodal extension. As with any of these staging parameters, I find extranodal extension kind of a difficult thing to assess in some cases. And if there is uncertainty, the general rules of cancer staging are that you call it negative. So extranodal extension in the CAP protocol is required only for HPV unrelated oropharyngeal and hypopharyngeal carcinomas, to say whether it's present or absent. The all components include providing the distance in millimeters from the lymph node capsule. If you're going to do that, again, millimeters, whole numbers is probably adequate. You can give to right? You can give it to a tenth of a millimeter, but I'm not sure that it's necessarily relevant or prognostically important. There are these subcategories of extranodal extension major, which means more than 2 millimeters, or which is less than or equal to 2 millimeters. That's an optional and really it's being collected just for data collection purposes by the AG, or it's suggested by the AGCC that it's collected for collecting purposes, not necessarily for treatment purposes. Some of these cases, you know, it's obvious that there's extranodal extension. You can see in this case of distinct lymph node capsule and tumor kind of bulging out and extending into the adjacent fat tissue. So that one's fairly straightforward. This one here, this is actually probably an HPV-mediated cancer. I can't remember, but it's non-keratinizing, so it probably is. So in this case, you wouldn't even actually have to report extranodal extension. But if you report it and reporting the distance, you report it from the outside of the tumor capsule to the most distant site. So in this case, you can see tumor extending outside the lymph node in adjacent fat with a lymph response in this case. And just to give an example of how you would measure it, and again, subjectivity involved, but if you follow the capsule along, the outer part of the capsule, the original capsule, is probably somewhere about here, and then the distant tumor is out here, so this would be your measurement. It's quite difficult in other cases, especially when you have widespread extranodal extension. So in this case, for instance, the tumor is clearly outside of the node. It's surrounding these vessels, and it's within fat. Where do you measure it from? We're outside of the capsule. I think there's a lot of subjectivity involved. And in this case, you can see the node is over here with tumor and down here, and there may be part of it over here. This is probably somewhere around the hilum of the node, but there's quite extensive nodal extension. Where exactly you measure it from, again, is rather subjective. The head and neck as well, sometimes you see these nodes which really don't have a very defined capsule, or nodes where you can, you clearly see there's reactive lymphoid tissue external to what I would consider to be the capsule. So these are issues to me that aren't always clear, and I think there's subjectivity involved, and always, I think when you have these cases that are questionable, it's an idea to confer with your colleagues who are determining extranodal extension in other sites, for instance. Try and maybe come up with some consensus in your group, and try not to beat yourself up too much about it, because you can easily start beating yourself up about these things, but they are very subjective. Okay, additional pathologic findings, again, the presence or absence of keratinizing or non-keratinizing dysplasia. That only refers to HPV-unrelated cancers. The N categories, just to show you the difference between those. So in HPV-mediated cancer, there is no relevance of the extranodal extension. So basically, N1 is 1 to 4 lymph nodes, and N2 is 5 or more lymph nodes. In HPV-unrelated, oropharyngeal and hypopharyngeal squamous cell carcinomas, and it's basically the same throughout all the head and neck sites. External extension does come into play. So in the old category, for instance, a single ipsilateral lymph node 3 centimeters or less would be N1. But if this node has external extension, it's bumped up to an N2A. Same for the N3 category. In the old system, N3 was any lymph node more than 6 centimeters. But now tumors are bumped up to N3 if more than 3 centimeters and have extranodal extension. So that's an important distinction. So let's quickly go through some of the other protocols just to emphasize some of the big changes. Major salivary gland protocol. And remember that for minor salivary gland tumors, whether it be in the oral cavity or in the cavity, you use that site-specific protocol. There are nomenclature changes in the WHO Blue Book for 2017, some of them fairly significant. So the entity known as mammary analog secretory carcinoma has been changed to secretory carcinoma. The entity known as polymorphous low-grade adenocarcinoma is now called polymorphous adenocarcinoma, and then you can give it a grade. And I mentioned before, there's no generic grading system for gland tumors, but there are tumor-specific systems, for instance, for adenoid cystic carcinoma, mucoid carcinoma, and adenocarcinoma NOS. P categories, you can see them here. I'm just bringing this to your attention because the issue of extraparenchymal extension really refers to clinical or macroscopic evidence of invasion of glandular soft tissue. So if you see microscopic extension outside the salivary gland, that doesn't really constitute T3 disease. But it emphasizes that you really have to examine these cases very carefully and try and assess on the gross specimen whether there is glandular extension, because in some cases, you're looking at a case and it's fairly obvious that there's a tumor outside a gland that must have been grossly visible, but it isn't grossly described. So it's important to assess these cases for gross extraglandular extension. There is an optional element for a high-grade transformation of gland tumors. I wouldn't. It is optional, but I would report it. This case that I'm showing you of adenoid cystic carcinoma, you can see the conventional adenoid cystic carcinoma with this sort of basaloid nest of cells, but it has transformation to grade adenocarcinoma NOS. This is an optional element in the CAP protocol, but if it's present, I think it's worth reporting because it does confer me anyway a higher risk of progression. The lip and oral cavity protocols, they introduced an element where you have to actually report the status of the tumor bed margin. So any of you who deal with these big head and neck cancer resection specimens know that you can either assess the specimen margins or you can assess the tumor bed margins. And some assess both. So what they've introduced really is that the tumor bed margins should be separately assessed in addition to the specimen margins, which would be the main specimen resection. So there are categories for whether or not these tumor bed margins are oriented or unoriented, and whether or not they're involved by invasive tumor or uninvolved by invasive tumor. This is required for squamous cell carcinomas of the lip and oral cavity, which, of course, are the most common malignancy that we see in these sites. So it's clear that, especially with respect to the deep margin and the soft tissue margins, the margins that you obtain from the main resection specimen in these head and neck cancer cases is of more reliable prognostic value than the tumor bed margins. Tumor bed margins can be reliable if they're mucosal, especially if they're given circumferentially around the entire specimen. The question is addressed in the protocol as to whether or not the tumor bed margins can be considered final negative margins if specimen margins are close or positive. And they discuss certain situations in which you can really rely on the tumor bed margins as being true negative margins. So, for instance, oftentimes you'll get a specimen resection and a little small biopsy of something called deep margin. And the deep margin might actually be many square centimeters in size. And so get a tiny little specimen called deep margin, then I don't think it's really relevant to call that a true negative margin. The criteria by which we can consider the tumor bed margins adequate for designation of a final negative margin. So they enumerate those. So first of all, they have to be properly oriented as to the true new margin surface. So that usually implies the surgeon, or in correlation with the pathologist, putting some ink on that on the true surface, and thick enough to process radially. In other words, you get a strip of tissue, say on the deep aspect of a tongue resection. If it's thick enough, you can actually section it and process it radially, and see on each section some margin, and you can potentially tell how far that tumor is from the margins. That's the ideal way to process that. Important also to know the physical relationship between the new margin and the specimen that you have. So if you have all those fulfilled, then it's reasonable to consider tumor bed margins as being final negative margins. But just to give you some indication or an example as to why it's important, if you can, to assess the actual specimen margins, ideally at the time of surgery, this case is kind of illustrative. So this was a mastectomy, and the tumor sort of towards the anterior aspect, which is a little bit out of focus, but there's this ulcerated tumor, and then the surface mucosa is a little bit abnormal here, but which was of relevance, in fact, for re-resection was way down here. And we cut across this tumor. You can see that towards the anterior aspect of the tongue, you can see dorsal tongue mucosa right here. This would be kind of the dorsal margin. This is the floor of the mouth. And here you can see this tumor with central ulceration. And this is actually clear of the margin. But get back, and this specimen is, or this piece of tissue is kind of flipped over, so we're looking at it from front to back. But you can see way back in the sort of posterior aspect of that specimen, you can see invasive carcinoma right here, and this little tongue of tumor, which is actually extending very close to that floor of mouth margin in the posterior aspect of the specimen, was completely unsuspected by the surgeon and warranted a re-resection of that area. And if you look at it microscopically, you can see that, in fact, that tumor was within a millimeter or so of that margin, even though it was completely clinically unsuspected. Just a word about the inking of the margins. Put ink on these specimens, you can get ink everywhere. It tends to kind of run into little crevices between the muscle. Sometimes because of the way they're resected, the tumor can kind of split a little bit, and you have splits in muscle. Sometimes you can even get splitting of the mucosa. You have to be very careful with the inking. And I always prefer to put ink on roll it on with a Q-tip rather than slide on with a sponge. The other thing I wanted to talk about is that, with respect to the lip and oral cavity, is this business of depth of invasion. So PT categories for lip and oral cavity do incorporate the depth of invasion, and as I said before, basically they can bump that tumor to a higher T category. For instance, if you have a tumor that's less than 2 centimeters, which previously would have been PT1, if it's more than 5 millimeters depth of invasion, it's called a PT2. So that depth of invasion is very important and is relevant to give. And tumor invasion, different than thickness. So tumors can sometimes be very exophytic, and it's been discovered that, in fact, what is more relevant is the actual depth of invasion beneath the adjacent, as measured beneath the basement membrane of the adjacent attacked mucosa. So this is an example from the AJCC book as to how you would measure it. And I give easy examples here, but sometimes this is not easy to assess because these tumors and these specimens can be very irregularly shaped. Sometimes they're completely ulcerated. Sometimes you really have difficulty knowing where to measure from. So again, don't beat yourself up about it. The other optional category in the lip and oral cavity section is the worst pattern of invasion. So this is really a component of something called the histologic risk model, which was, there's been these histologic risk models which have been developed, and the sort of most accepted one is by Gensler. And the pattern of invasion is a component of the histologic risk model. And what's been found really is that the worst pattern of invasion, category 5, is of major significance. So that really refers to a pattern in which there's satellites of tumor around your main tumor mass, and these satellites are dispersed from one another by more than a millimeter, or at least a millimeter from the main tumor mass, with kind of intervening normal tissue. And that's a predictor of tumor recurrence, both locally and in the neck. There's a discussion of it in the new manual. And these little satellites can get there in various ways. They can get there along nerves, they can get there through vessels, or they can get there through soft tissue. But in experience, these are a common source of close margins in oral cancer. So you have a tumor that the main bulk of which is well clear of the margin, and then you have little foci that are multifocal or from the main mass that can be very close to a margin. So additional category, but I think probably worth considering. So of what I'm talking about is actually worst pattern of invasion 5 due to perineural invasion. So there's no main tumor mass here. You can just see this little focus of tumor less than a millimeter in greatest dimension, fairly close to a margin, and clear around a nerve. Okay, larynx, not a whole lot to talk about here, except to everybody, the categories in the larynx are not 3-tiered, they're 2-tiered. So mild is low grade, and moderate and severe carcinoma in situ considered to be high grade. Basically, anything high grade in the air digestive tract is considered a positive margin. So moderate or above. And of course, in the upper airway, and particularly in the larynx, display is usually keratinizing dysplasia, so you may see actual maturation of the cells on the surface, and yet it's still severe, and that is essentially synonymous with carcinoma in situ. It is synonymous with carcinoma in situ. Over this, we're getting actually probably over time, except to say that oropharyngeal cancer is not the only HPV-related cancer in the upper airway, and you do see other types of HPV-related cancers. And a recently described one is called HPV-related multiphenotypic sinonasal carcinoma, used to be called HPV-related carcinoma with adenoid cystic carcinoma-like features. It's unique to the sinonasal tract, and interestingly, the majority of these cases are associated with HPV type 33 when it's been tested. And these tumors, in a similar way, I guess, to oropharyngeal cancers, can be quite large and destructive, and yet they're relatively indolent and respond well to treatment. So I'm going to go over the images just because we don't have time to discuss it more. The nasal cavity, just keep in mind that sometimes you'll see squamous cell carcinoma arising in an inverted papilloma. The books do that squamous cell carcinomas develop in up to 27% of inverted papillomas. I see inverted papillomas with malignancy, of the year. Maybe I'm missing them. If the carcinoma has completely replaced the inverted papilloma, I only see many papillomas without squamous cell carcinoma. These are usually conventional keratinizing squamous cell carcinomas. I guess the only things that I would say about it are that, first of all, sometimes these tumors are preceded by multiple recurrences of inverted papillomas, and typically don't see a low-grade element. So what you will usually see is you'll see the inverted papilloma, and then you'll see adjacent to it this high-grade-looking cancer, kind of nested and not obviously invasive, but eliciting a whole bunch of desmoplasia. So these are invasive tumors if they do appear to be, quote, situ. Okay, getting to the end now. Just a few notes about HPV testing from the new CAP guidelines. And this is in the Archives of Pathology and Laboratory Medicine. I think you get it as a preprint. I don't know if it's actually been published yet. So, summarize any oropharyngeal squamous cell carcinoma, regardless of morphology, should be tested for HPV using the surrogate marker of P16. If more than 70% staining and it's nuclear and cytoplasmic, it's considered an HPV-positive squamous cell carcinoma. Treating is not applicable. If it's P16, so less than 70%, it's an HPV-negative squamous cell carcinoma, and grading is required. Sometimes you will have these equivocal results where it might be 50 or 70% positive. I think cutoff using for the Ontario is 50%. You might see a different 7%, I think, is what's in the AJCC. So, you know, I think it's up to the discretion of the pathologist to test if you have an equivocal result. But in my experience, it's usually almost all positive or negative or very minimal. It's not required to routinely test non-oropharyngeal squamous cell carcinoma for P16, even though you may get requests by the clinical staff. So then we get to the issue of cervical lymph nodes, the upper aspect of the neck, so level 2 or 3, with squamous cell carcinoma, unknown primary. So it's very uncommon to have oropharyngeal squamous cell carcinoma that metastasizes to any level other than 2 or 3 without having metastases in level 2 or 3. So just primary metastases to like level 4 or level 5 with 2 and 3 metastasis would be very unusual for an oropharyngeal carcinoma. With P16, if you get more than 20% staining and it's non-keratinizing morphology, then it's metastatic squamous cell carcinoma HPV positive, and it is staged according to the oropharyngeal chapter of the book. If it's non-keratinizing morphology, then I recommend doing HPV-specific testing, like hybridization for mRNA, for instance. If you do P16 and it's negative, so it's less than 70%, then it's considered to be metastatic squamous cell carcinoma HPV negative. About HPV testing in cell blocks. It's not uncommon to have requests for those who have neck masses with squamous cell carcinoma and an FNA to have tested for P16 or some other type of HPV-specific testing. We know where the primary is or where the primary likely is, and ask this to do this frequently. It's quite uncommon, I think, here for treatment to go ahead based on P-staining and an FNA only, but it may be common in other circumstances. So it's really important that you validate this test if you're going to be using it in your own institution. I find it very difficult to tell if you're dealing with a keratinizing or non-keratinizing to an FNA sometimes, unless you get little tumor fragments, which are basaloid tumor cells, because these tumors can mature and they can keratinize, especially in lymph nodes. So done this P16 staining on cell blocks and kind of developed some guidelines. I mean, you can't really just do it on isolated cells in a cell block. We fear that you have to have 50 cells in little aggregates of basaloid tumor cells. There has to be some nuclear staining present, at least cytoplasmic staining as well. But I think our experience is similar to other institutions in that the extent of positivity can really be quite low in cell blocks and be strongly positive in formalin fixed paraffin embedded samples. So my rule of thumb is if you get a biopsy or a surgical specimen, I always repeat it, and a negative cell block result does not necessarily exclude a negative P16 result. Or that's an error. It doesn't exclude a positive P16 result. So to give you an example, so on the bottom here, you've got a clearly positive oropharyngeal squamous cell carcinoma. You have a fragment of tumor tissue from the cell block, and you've got pretty intense staining, both nuclear and cytoplasmic, in the majority of the cells. But where you had a very intensely positive formalin-fixed sample on biopsy, and you have a fairly decent fragment of basaloid tumor cells in the cell block, the thing is there, but it's fairly weak in the tumor cells. It's primarily nuclear. It's primarily weak. There may be a few cells that are staining positively. But the upshot is that you may have quite good staining in the cell block specimen and still have a positive P16 result. Mucosal melanoma, just to quickly mention it, for cases you use the appropriate site-specific CAP protocol. I have a dedicated chapter for mucosal melanoma in the AJCC 8. Most of these cases, at least 2/3 of them, occur in the nasal cavity, quarter perhaps in the oral cavity, but in my experience, they're usually in the sinonasal tract. And often the presentation is, sort of an elderly patient, like often an elderly woman with a nose mass. You think about melanoma. These are small cancers, but they behave very aggressively. They have a high mortality. And the reason the primary cancers, even limited to the mucosa, are considered PT3. Some do see in situ melanoma adjacent to an invasive melanoma, but I've never seen a pure one. So just to summarize the PT and PN categories, everything is at least T3. For that, just in the interest of time, I mentioned that there is a CAP template reporting biomarker testing of specimens, including one specifically for the head and neck. It's a new document. It replaces the ancillary testing components of the CAP protocol. It gives a nice summary of the not only the molecular changes that you get in head and neck cancer, but it gives a very nice summary of the immunohistochemistry that's available, and different molecular testing techniques are available. So if you're interested in that, it's a really good document to read. So that brings me to the end of the talk, and I'm sorry I went over time, but if there are any questions, I'd be happy to answer them.
Thank you very much. That was a great overview of a complicated area anatomically, and with a lot of changes coming to the checklist. There's a couple questions that have come through on the chat line. Julianor is asking, do you test your small cell neuroendocrine carcinoma using HPV molecular testing?
I've only had one case, and it was only P positive. It was clearly a carcinoma, and I know that there's a guideline for it, and I can only tell you that I didn't. I'm not sure that it would be necessarily even relevant because they behave aggressively. As far as I know, they'd be treated the same way as you would treat an HPV small cell carcinoma. So that's my answer, but I stand to be corrected.
Okay. The second question is P16 a good surrogate for the pharynx subsite?
P16 a good subset?
A good surrogate for HPV molecular testing the pharynx.
Well, in the oropharynx, yes, absolutely. So that's really the major points of the new CAP guidelines that are just been published in archives. The sensitivity of P16 or HPV is high. It's close to 100% when it's compared with the mRNA-ish, for instance. So there's very good correlation between of P16 positivity and HPV by methods, by HPV-specific methods. It's not entirely specific, so you can have P16 positive squamous cell carcinomas that are HPV negative, but in fact they may behave in this sort of prognostically bad fashion anyway. And such a good marker that in the oropharynx, yes, it can be used as a substitute for HPV-specific testing. Sites and non-squamous cancers, no. So P16 is not as specific or sensitive in other sites. Why sensitive? I'm not sure about sensitivity, but definitely it's not as specific in other sites.
Now, a question related to squamous cell cancers. Do you know if lung squamous cell cancers are HPV separated?
HPV separated.
Is there any role for HPV in lung squamous cell cancer?
I really can't answer that because I don't deal with it on any regular basis.
Okay, no problem. Okay, question from Mark Reichenberg. Why do head and neck cancer centers need to repeat P16 testing on cases that are strongly and diffusely positive when tested in a community hospital? I guess I could paraphrase that to say, do you repeat the testing at your center if you get P16 done outside on a referred case?
Yeah, that's a good question. I think it probably depends on the referral center. I don't repeat them if it's really a positive result. I mean, usually what happens is in Nova Scotia, where it's all part of the same health authority, and so there are differences between the labs. We've tried to some consistency between the labs about the immunostaining protocols, and I know most of the pathologists personally, they use P16 free. And if it's positive, it's positive. If it's more than 70% positive and nuclear and cytoplasmic, then that's a positive result. And as I said before, it's usually diffusely positive, almost 100% positive. So I, at least in the referral group that I have cases from, I don't repeat them. If it's non-keratinizing and if it's negative, and I think it's really an HPV positive tumor, and it's been reported as negative or equivocal, yeah, I'll repeat it. But if it's a clearly positive result and I'm familiar with the center, I don't repeat it.
Okay. Question from Sherbrooke asking, what is the head and neck panel that you recommend?
The head and neck panel.
Yeah, you have a panel of immunohistochemical stains, or I guess a panel of testing that you would recommend routinely in head and neck cancer?
I think it's very dependent on the cancer and on the site. I don't know that there is a panel that I could recommend. I assume we're talking about immunohistochemistry, are we? Yeah.
The panel, I assumed it was immunohistochemical, not a molecular panel at this point.
Right. I think I'd say is that they're in neck sites because you often have small biopsies, and sometimes you can be fooled into thinking that you have adenoid cystic carcinoma in the nasal cavity when in fact it's one of these multiphenotypic sinonasal carcinomas that are HPV related, the adenoid cystic-like cancers. You can be fooled into thinking that you have a squamous cell carcinoma at the base of the tongue that is actually an adenoid cystic carcinoma or a polymorphous adenocarcinoma. They overlap, and small biopsies can present a lot of challenges. I guess what I can say is that I'm not really familiar with looking at them in them a little bit more rather than making the sum about what you're dealing with.
We have two questions remaining. One of them is related. I'll skip to that one first. And that's how often do you employ an immunohistochemical panel in subcategorizing salivary gland tumors?
Quite, actually. Maybe more than's necessary, you know. I'm really liberal with immunohistochemistry on gland tumors because I'm interested in them. But, you know, especially if you just have a salivary gland tumor and a biopsy, those are difficult to solve. So salivary gland tumors really is a histologic pattern recognition, but I personally tend to use quite a bit of immunohistochemistry.
The question that we have is there's two parts. It has to do with tumor and vascular spaces. The first part is, do you consider the tumor and vascular spaces when assessing the worst pattern of invasion? And part to the question is, if tumor within the vessels is to the margin, do you report the distance from the main tumor or the distance from the tumor in the vessel?
Yeah, that's a good question, because when they talk about invasion 5, two vessels could be the source of worst pattern of invasion 5. But in most cases, it's not really easy to see the vessel in that circumstance. So, you know, if you have a tumor that's clearly in a vein, report that as pattern of invasion 5. I would report that as venous invasion, and I would distance of that from the margin, but I would, you know, make it clear in a comment that this is vascular invasion, and so, you know, the distance kind of, I guess, be not of a great deal of relevance. So I would also report the distance of the main tumor or the other closest invasive tumor from the margin. So I do draw that distinction of what I clearly know to be vascular invasion from soft tissue invasion. I think that's an important distinction to draw. The worst pattern of invasion 5 comes from small invasion, but it's not recognizable as such.
Okay. There's one question that just came in, and that'll be our last question, and that is, can you comment on the approach to an experience with brachial cleft cysts in adults and B16 positivity?
That's branchial cleft cysts in adults, they differ, no doubt about it. And so the things are that you really keep it in the top of your mind that when you have a cystic neck mass with squamous cells in it in an adult, especially an adult male over about 40, that's likely to be metastatic oropharyngeal squamous cell carcinoma and not a branchial cleft cyst. That's an important thing to keep in mind, especially if you do cytology. You do see branchial cleft cysts in adults, and I guess from time to time you might get FNA of one of those, I suppose. I haven't had any experience with that. On histology, there's often some of that mosaic positivity, similar to what you see in the tonsillar crypts. So you see individual tumor cell or individual cells, squamous cells, and groups of cells with varying intensity of positivity, but which does not constitute the strong staining more than 7%. So you do see staining in branchial cleft cysts, just the way you do in tonsillar crypts. But what you're looking for is replacement of the epithelium by malignant cells, right? That is metastatic squamous cell carcinoma. Whether you can have squamous cell carcinoma arising in a branchial cleft cyst, I suppose it's theoretically possible, but it is only diagnosed under very, very strict conditions. I've never diagnosed it. You could have I guess the question would arise as to whether or not you could have an FNA of a branchial cleft cyst that might stain with P16 on an FNA. Possible, I think unlikely, but possible that you would get a few cells that stain, and that's why you have to validate assessment of P16 on cells at your institution and decide where the appropriate cutoff lies. Some people set a cutoff of as little as 10%. But that's a very valid point and one that's worth considering if considering doing P16 on cell blocks. Sorry, just to say one other thing though. One thing is that if you have an FNA of a branchial cleft cyst, you would not expect to see elements of basaloid tumor cells. And that's what you need to have to assess. That's why you can't just assess it on individual tumor cells floating around on the cell block. You really have to have fragments of basaloid cells that you can assess on the cell block before you start doing P16.
Okay. I read that we're a couple minutes over time, but there was an additional question that came in. If you don't mind, Martin, I'll give you this last question.
Sure.
It's how often do you resort to molecular testing in salivary gland tumors? Which tumors?
Well, I say uncommonly, the way that I do resort to molecular testing, that I've kind of historically resorted to molecular testing, is on mammary analog secretory carcinoma, which is now secretory carcinoma, which has the ETV6 TRK3 translocation. And I've always historically done it for confirmation and just so that I could kind of have a really thorough understanding in my own mind of what this entity is and what the spectrum of features that you can get. So still in most cases do it. Everybody does. Head and neck, pathologists don't routinely do it en masse. there are tumors like a hyalinizing clear cell carcinoma, where I would do the testing for, I'm sorry, it's just escaping me at the moment. But mainly on others, no, not. There's really some conundrum I want to solve, like a differential diagnosis with a mask, for instance, trying to confirm that, but I don't do it frequently.
Well, thank you very much, and thanks for everybody for staying a few extra minutes. Those are a number of very interesting, very relevant questions. I thank you for taking the time to answer the questions that came through. Now, on behalf of the Canadian Partnership Against Cancer, Cancer Ontario, and the Canadian Association of Pathologists, I'd like to thank Dr. Bullock for the great presentation today. And both the live and recorded presentations are eligible for continuing education credits. To request your certificate of participation, please put your name and email address at the link included in the session notice. You will also find an optional session evaluation form, which we encourage you to complete. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions. And please see the session notes for more information. I'd also like to draw your attention to two upcoming sessions. They include Colorectal Cancer with Dr. David Schaefer. That's March 14th. And after the USCAP meeting, we've got Dr. Julia Keith presenting on brain and CNS tumors on April 11th. To everybody.